Good afternoon. Today, I'm going to be speaking to you about fracture non-union, a treatment algorithm. My name is Michael McKee, and I'm the professor and chair of the Department of Orthopedic Surgery at the University of Arizona College of Medicine in Phoenix, Arizona. These are my disclosures. I do have one relevant disclosure in this area, and that I'm a consultant for Bioventus. My disclosures are also up to date on the American Academy of Orthopedic Surgery website. The learning objectives of today's webinar include reviewing the current data and highlights regarding current non-union clinical challenges and current treatment strategies, to develop standards and an algorithmic approach to managing fracture non-union, and to identify cases in which orthobiologics would be most beneficial. When we look at patients who have a non-union, the first and most critical aspect of their treatment is to carefully assess what they are, both in terms of patient factors and fracture factors that may influence the healing of an associated fracture or the development of a non-union. Patient factors include smoking, the patient's nutritional status, their compliance level, whether they're a substance abuser, which is particularly relevant in today's society, whether they've had previous bariatric surgery, etc. Fracture factors that you need to consider include the presence or absence of infection, the stability at the fracture site, whether there's adequate soft tissue coverage, whether there's acceptable deformity or unacceptable deformity, and what the natural history of the particular non-union that you're dealing with is in the medical literature. I think one of the most interesting papers I've come across looking at non-unions is this paper discussing common factors in non-union patients. This is in the Journal of Orthopedic Science in 2014, comes from Japan. They investigated 102 consecutive patients with non-union, and they found that 24 cases were clearly due to mechanical reasons with inadequate fixation or poor surgical technique. 23 cases were due primarily to biological factors, and this is a situation where treatment was appropriate, surgery was appropriate, fixation was reasonable, and yet due to biological factors in the patient, this fortunately progressed to non-union. And 55 cases had a combination of factors, so that both mechanical and biological factors combined to produce a non-union. I like this paper because it mirrors my own experience, both in dealing with referred non-unions and my own, in that about half the time there's a combination of factors, half the time it's due to mechanical reasons, and the other half of the time it's due to biological factors. So in general, this is a very accurate paper, I find, and that it reflects on my own practice, and that it makes common sense and it's easy to remember. So these are the kinds of factors I'm considering when I see a patient with non-union. We also have to remember compliance, and I think we have to discuss the compliance and substance abuse issue in conjunction with each other, because unfortunately, substance abusers have a much higher instance of non-compliance. This is a patient that I spent a number of hours carefully reconstructing a tibial plafond fracture with small incisions and plates and screws to put everything together very carefully and delicately. Instructed him personally and carefully to be non-weight bearing on this to protect the repair that we performed. And this is how he comes back to clinic 2 weeks later. And you can see that my instructions for non-weight bearing haven't really been followed. And this is a critical factor in dealing with patients who have non-union on a number of different levels, as we'll discuss further in this talk. We have at least one paper out that clearly shows in clavicle fracture fixation, the risk of a non-union is roughly 5 to 10 times higher in a substance abusing or non-compliant patient. So especially in situations where fixation is tenuous or the reconstruction is delicate or difficult, you need to consider this factor clearly or you'll have an unhappy result. What factors are important? Well, nutrition and metabolism issues are common, and it makes common sense that if you have poor metabolism and poor nutrition, this is going to affect fracture healing as it would affect any other biological process in your body. They influence your prognosis for the patient, preoperative assessment, preoperative consultations that you wish to obtain before you proceed with surgery, preoperative planning. It may mean that you have to add biology at the fracture site for someone who has tenuous metabolism or tenuous nutrition, intraoperative decision-making, what you find during the surgery, and post-operative care. And there are actually papers that support all of these different factors when it comes to nutrition and metabolism. And only now are we becoming really much more aware of the importance of nutrition and metabolism for some of the fractures that we fix and some of the non-unions that we see that result. This is a paper from the Annals of the Royal College of Surgeons in England in 2016, looking specifically at patients with hip fractures and femoral neck fractures. And they looked at 251 patients, so it's a fairly large series. And they focused on the 37 failures that they had. So they had a significant failure rate with the treatment of femoral neck fractures, as we all do in 2021. And they said, well, why did these fractures fail? What they found was that a low preoperative serum albumin correlated with fixation failure very clearly, and that the age of the patient, the gender, which side was done, and even the technique really did not. So of all the factors that they looked at and considered, the one factor which was most important or correlated most highly with fixation failure was a low serum albumin, which is of course a surrogate for malnutrition in a preoperative patient. Now, a low serum albumin of itself may not be the only thing, and there's a host of other factors that go along with that for someone who has low serum albumin, but this was the one factor that correlated most with fixation failure in this relatively large series of hip fracture patients. This is a patient of mine who had a displaced femoral neck fracture. This was done a few years ago, and he was relatively young, so we felt that fixation was indicated as opposed to a hemiarthroplasty or arthroplasty of some kind. You can see the fixation there, perhaps not ideal compared to today's standards, but not too bad either. A well spread out screws in the head and neck, a very decent reduction, and no varus lesions initially. But you can see already here that this patient has started to develop a non-union with backing out of the screws and failure to heal at the fracture site. Well, why did this happen? You could argue that perhaps there could have been some refinements to the surgical technique. But we also have to point out this patient was an alcoholic, was malnourished with a very low serum albumin, very low vitamin D level, and he lived in a shelter where his conditions were far from optimal. So this patient is going to need some kind of revision surgery for this, and a very important part of the decision-making and what he's going to have done are these issues here, patient factors. You know, can his alcoholism be corrected at least temporarily? If you want to try and redo this and fix this, he's relatively young. Malnourished, is it possible to have better nourishment here before you try and do this? We know that malnourishment and a low serum albumin can affect this specific type of fracture. And is it possible to get him to a better environment post-operatively to maximize his chance of healing this difficult situation? So there's both patient factors and fracture factors to consider in this kind of setting. Well, we see, unfortunately, a fair number of patients who are very obese these days, and this has become an epidemic in North America. And just in the last week or so, anecdotally, we've seen 2 individuals who were morbidly obese who fell from a standing height and sustained knee dislocations with popliteal artery ruptures. This is an issue we literally never saw before, but now with the obesity epidemic, and I think it's reasonable to call it an epidemic, we see these injuries and we see complications of these injuries that we simply did not see very much before. Well, how is it that someone can be overweight but malnourished? And this is actually a significant problem, and there's a good critical care paper on this in 2015 by Lasakian and group, talking about how it's possible to be severely overweight, but still, if you look at the basic parameters of nutritional status, vitamin D, important for us, obviously, serum albumin, total serum protein, etc., these patients are overweight, but they're seriously malnourished. And this is something that you have to consider. And simply because someone's obese does not mean that the nutritional status is good. In fact, some would argue it may be the exact opposite. And this is in addition to all the physical and mechanical parameters you're going to face in fixing a fracture in an obese patient, the added stress and strain on your fracture, the difficulty with surgical exposure, possibly a higher infection rate depending on what fracture that you're dealing with. What about bariatric surgery? There's been a lot of interest in bariatric surgery and orthopedics recently because a lot of individuals who are obese or morbidly obese have significant problems with lower extremity arthritis, and that hip and knee replacement is a common procedure in these patients. We think that if these patients can lose significant weight preoperatively, that this may improve their overall status and their overall outcome and reduce complication rates. And this is something that's obviously of interest to us. When you've had bariatric surgery, there's a variety of different kinds possible. There's simple sleeve techniques around the distal esophagus. There's various balloons that can decrease the size of your stomach, gastric staplings, even more complicated intestinal bypass operations. The bottom line seems to be that it has a significant and negative effect on your calcium and vitamin D metabolism. It can decrease bone density, and it can accelerate bone loss significantly, as well as induce various hormonal changes. I think of these three papers, if you wanted to read one that was slanted towards the orthopedic surgeon to give you a good, comprehensive and general view of what bariatric surgery means for us, I think Kingsburg's summary or primer, as the title would suggest, in the American Journal of Orthopedics is an excellent one to look at and really gives you good information. The paper by Smith et al. Looks specifically at, does bariatric surgery prior to hip or knee arthroplasty reduce complications? And the systematic review always, it shows different information from different papers, as you would anticipate. But in general, it showed that this was probably a good thing. I actually worked as an intern on a bariatric service for a few months. And interestingly enough, a lot of those individuals who had bariatric surgery and lost 100, 150 pounds, who had chronic painful orthopedic conditions pre-surgery, had dramatic improvements in their pain and discomfort of their lower extremity problem after they had bariatric surgery, to the point where they didn't want orthopedic surgery anymore. So a significant weight loss, and by that I mean over 100 pounds or so, to make a huge improvement to chronic MSK conditions in general. And if you do have to have surgery, despite that, the complication rate may be significantly improved, but it does have a bad effect on bone. I've seen a number of bariatric patients with non-unions despite a fairly good mechanical fixation and adequate fracture surgery. One of the most interesting papers, I think, that really opened up the whole door about non-union metabolism was by Mark Brinker, who is from Houston. He wrote this paper back in 2007, which is a significant period of time ago, looking at 37 patients with unexplained non-union. Well, what is an unexplained non-union? That's a non-union that occurs in a bone that usually heals, that has an adequate fixation, or an undisplaced fracture, or multiple fractures with at least one non-union in a low energy mechanism. So if you look at the 37 patients he identified, they all had non-unions where, if you looked at the original x-rays after fixation or initial treatment, you said, will this fracture heal? You would say, yeah, it should heal without any difficulty. When they went on, they didn't. And so he tried to look at, why didn't these fractures heal? And he found, very interestingly, 31 of 37 of these patients who had an unexplained non-union, and by that I mean a fracture that frankly should have healed and didn't. 31 of 37 had some type of identifiable metabolic or endocrine abnormality. Vitamin D and calcium metabolism were the commonest, but hypogonadism, hypothyroidism, parathyroid issues, etc., were common in this group. And the more carefully you looked for issues of this nature, the more likely you were to find them. I myself saw a patient last week with a moderately displaced clavicle fracture, an otherwise healthy patient that didn't heal. And I would have said it had a pretty good healing chance at the time of the initial injury. And it wasn't that badly displaced. It was closed, obviously, and good bony contact. Went on to a non-union. That patient turned out to be hypothyroid. Now, I didn't discover that, but someone else did. But that's certainly something that you have to address and treat before you want to have a surgical intervention on the non-union. And certainly the treatment of her hypothyroidism was an important thing to initiate before we attempted any surgery, for a variety of reasons. So the more you look for some kind of metabolic or endocrine abnormality, the more likely we are to find it. And the obvious ones for us, of course, are the vitamin D related ones, but all these other issues can be there as well. Mark, in a few talks, has also said that in the other 6 patients who didn't have one of these issues, it probably was just a matter that we don't have the sophisticated enough testing to figure out exactly what is an issue with those other individuals, but they probably have something else going on as well. So this is a very interesting paper if you want to look at metabolism and non-union in this population. So what kind of algorithm? I think that I use, I think if you are going to treat a non-union, probably the most important thing is to correct any kind of underlying metabolic deficiencies. Dr. Brinker in the previous paper reported that 8 of those patients with an established non-union were able to be corrected or healed without any surgical intervention, just by correcting the biology of the patient. So if you have an identifiable metabolic deficiency and you correct it, you may even save the patient's surgery. And if you don't, you can at least optimize the environment that your surgery is going to take place in to make the chance of technical success maximal. So I look for and identify metabolic deficiencies, especially in patients who have a fracture that should have healed or you would have expected to heal, but that didn't. If there's a significant biological issue and the patient, and some of them are simply obviously not correctable in certain situations, then a useful adjunct is some kind of pulsed ultrasound or low intensity pulsed ultrasound, or LIPUS as it's known. And I think that there's compelling evidence that in the proper situation, this kind of adjunct can definitely lead to healing of a fracture or a non-union that might otherwise not do well. If you have an unstable situation or significant deformity, unacceptable deformity, so even if the fracture did heal or the non-union did heal, it would heal in a position that was unacceptable for function, then usually that patient's going to need corrective surgery. If you have infection, and this is an important point, is that sometimes fractures that should heal don't because of underlying infection. There are obvious infections with a red, angry wound or a draining sinus or pus in and around the fracture site draining through a wound. Those are obvious. However, there are more subtle ones, such as a low-grade organisms, such as C. acnes or staph epidermidis, that really don't present with those obvious signs of infection. They just grumble away at the fracture site, and they can produce significant biological impediment to fracture healing. And those are the ones that we have most difficulty identifying and treating. There's a great paper out of New York looking at clavicle fractures that were plated that didn't heal despite an adequate technical job. And so if you plate a clavicle fracture and you do a good job and it doesn't heal, that's unexpected because the union rate is around 99% in most series, or 98%. And what these authors from New York and HSS found was that there was a significant rate of underlying C. acnes infection in those cases. So for example, in the shoulder girdle area, a non-union and something that was expected to heal often is a result of underlying C. acnes infection, and the surgeon needs to be alert for that. So as a rough guide to the algorithm we're going to talk about, metabolic deficiencies, correct those if at all possible. We'll talk about smoking later. Correct as much as you can before you decide to operate on an individual. If it's a pure biology and otherwise stable and well-aligned fracture, then adjuncts like LIPUS can make a big difference. Obviously, unstable, deformed, or infected cases usually are going to require some type of surgical intervention. Well, what about non-unions in particular areas? I'm going to talk a bit about scaphoid non-unions here. I do have a bit of a side interest in upper extremity issues, and I see a fair number of scaphoid problems. And of course, the scaphoid is a bone in the wrist that doesn't want to heal. This is a relatively young, healthy patient who came in with a wrist injury. And you can see, if you look at the original radiographs, I really don't see much there, and neither did the treating surgeon. 6 weeks later, you can see there's something vague going on in the middle of the waist of the scaphoid there. And it looks like the proximal pole is becoming a bit white or osteosclerotic, which, as we know, is a sign of a fracture and subsequent avascular necrosis of the proximal pole. And then by 3 or 4 months out, when he comes to see me, you can see that in addition to ongoing clinical symptoms of pain and stiffness in his wrist, this patient has a clear-cut fracture line and some cystic resorption going on around an established delayed or non-union. And so this is not an uncommon story for scaphoid fractures, because for a variety of reasons, they don't want to heal. There's tremendous force around the carpus as the link between the proximal and distal rows. They have relatively tenuous blood supply that kind of goes in a retrograde fashion, so that's not very good. And they're bathed in synovial fluid. So really, it's an ideal environment, unfortunately, for developing non-union. That's why we see so much scaphoid pathology. There have been a couple randomized trials looking specifically at the benefit of using a LIPUS or some type of ultrasound in fresh scaphoid fractures. This particular one, published a number of years ago by Mayer et al., looked at stable scaphoid fractures, these ones that were mid-waist, not displaced, not associated with other carpal instability patterns. And they looked at cast alone versus cast plus ultrasound. And they found that this is a pretty good study, I think, and they used CT scan to define union. I think most, to digress briefly, most studies now, if you want to get them funded looking at scaphoid fractures in union, you pretty well have to get a CT scan to ascertain or decide on union, because it's so difficult to tell with plain x-rays. So they did a CT scan every 2 weeks, and they found that the mean time to union was significantly decreased in the ultrasound group. And these were CTs read by blinded observers. So it looks as if you want to get, if you don't want to do surgery on these individuals and you want to get them out of a cast and heal as quickly as possible, that there may be some significant advantages to a LIPUS application. And certainly it's become, I think, almost standard of care for many professional athletes, where return to play or return to function is critically important and a huge economic issue if you're making millions of dollars a year to play a sport. I thought I'd show a few cases of my own that sort of illustrate some of these points. This was a 37-year-old male who had a displaced scaphoid fracture with some comminution. He was treated with a cannulated screw and no bone graft, and we don't usually bone graft fresh fractures, as you know. This was his fracture here, and you can see there's a little bit of lateral comminution there on the radial border of a waist scaphoid fracture. And you could argue what ideal treatment for this patient is, but I thought that fixation was definitely indicated. This patient came back at 6 months, and I think we've got pretty good fixation here. You could argue the screw maybe could be a little bit more vertical in nature in the distal pole, but a pretty good alignment in the proximal pole, which has been shown to relate to outcome. There was no deformity. Patient wasn't particularly painful, but wanted to get back to doing some heavier things. And I felt awkward letting him do that. If you look at this fracture, it still doesn't look completely healed. You can still clearly see the fracture line 6 months out. But I thought this was an ideal situation for some type of biological stimulus. This patient has good alignment, has stable fixation. We're not looking at loosening of the screw here. And if we just get a little biological push, so to speak, at the fracture site, then this should be a fracture that goes on to heal. So our options here were a number, but we added a LIPUS at 6 months, and at 9 months, you can see there's pretty gratifying consolidation at the fracture site. So this may have happened anyways. You know, one case doesn't prove a lot, but I do think that the application of LIPUS in this case significantly accelerated the healing at the scaphoid waist, and that was good for this patient. And if you have this x-ray, I think you'd be quite happy letting this individual go back to more vigorous activities and repetitive impact type activities. So the indication for that particular case was a delayed union, at least radiographically, in a stable, well-fixed fracture with no infection and no deformity. I think that's probably an ideal indication for the application of something like LIPUS in order to promote union in that specific setting. Here's another case, a 45-year-old male orthopedic surgeon. He was actually the resource person in his area for revision hip arthroplasty. That was his niche. And he hurt his wrist in a snowmobiling injury 6 months before, had ongoing pain, discomfort, well-maintained range of motion, but about half normal grip strength. He was having a lot of difficulty working. And those are his radiographs here. And you can see there's, again, significant degeneration of at the fracture site with cystic formation. You can see a fairly sclerotic looking proximal pole. And if you look at the lateral, you can also see he's developing some carpal instability pattern with a scapholunate angle, which is obviously off. And this can happen with the progression of time in these individuals, which certainly does affect wrist function as well. This patient was treated by one of his partners with a screw fixation, a Bowler approach. Didn't use a bone graft, which I think probably was a technical error in this particular case, and was referred to me 6 months later and still quite painful. So I'll show you this case, which is in distinct contrast to the previous case. In this case, we've obviously lost mechanical fixation. We don't have a stable fracture. We have a screw, which has really got minimal purchase in the proximal pole. There is a large lytic lesion around the tip of the screw, and there's probably got no bite there whatsoever. So we have clearly a situation which I think would demonstrate a lack of stability and a lack of fixation at the fracture site. So I don't think this setting would be appropriate for just a biological stimulus. I think this patient needs to have something more done to promote union in this specific setting. This person needed a repeat fixation with better mechanics and probably a bone graft, and that's what we did. So we took out the old screw, we added a tricortical bone graft from the iliac crest, and there's a lot of debate about where the best place to get a bone graft for the scaphoid is. In general, I tend to be an old school surgeon in this regard, and a tricortical iliac crest graft I think is probably best if you have a significant bony defect there. If you're early on in the course of this issue, then more sliced graft, either from the crest or from the distal radius, may be acceptable. But I think if you have a mechanical problem with some collapse and some carpal malalignment, then probably a tricortical graft is best. And that's what we did for this patient here. This patient went on to heal fairly rapidly and returned to his practice. So in general, I think those two cases illustrate when LIPUS can help you and when they can't help you. My general indications for LIPUS are delayed or non-unions. We'll talk a bit about fresh fractures perhaps in another talk, but when I see a delayed or non-union, these are my specific indications. You need to have good soft tissue coverage. You can't have a massive bony defect. And, bony defects and critical size defects are somewhat controversial. If you look at the SPRINT study, which was a large randomized trial looking specifically at tibial shaft fractures, the previous definition of a critical defect in the tibia in a human, which is defined as a defect which predictably leads to a non-union and require a repeat intervention. They found that if you looked at the critical defects in those series, I think almost 60 or 70% eventually healed without further intervention. So it's clear that our definition, at least in the tibia, previously of what a critical defect was, may not be that accurate. So that's just food for thought. But I think if there's a bony defect of more than a centimeter, so probably LIPUS is not going to be enough to save the day, and you're looking at some kind of other procedure. If there's no deformity or infection at the fracture site, if you have an unacceptable deformity and the patient's not going to be happy with their leg or arm or whatever, regardless of whether it heals or not, then obviously that patient's going to need another operation. And the absence of infection. The data on LIPUS and infection is limited. And I think in general, in the human situation, probably active infection is a relative contraindication to using a LIPUS device. You need to have a stable fracture like the first case I showed you where the scaphoid was stable, just nothing happening biologically. And I think with the passage of time, if there's no evidence of progressive union or callus formation, you plateaued or you're static, then maybe this is the ideal indication for a LIPUS in that patient. I'll show you a few illustrative cases, and I thank my colleague Bob Zira for some of these. This is a 69-year-old male who's 7 months after having an ankle fracture while playing golf. You can see his treatment there. He had a lot of pain. He was 13 weeks out from his fracture, and most ankle fractures, as we know, are probably healed by this. So this fracture is behaving differently than the natural history of most lateral malleolar fractures. He was recommended by the local surgeon to have surgery, which I think is reasonable looking at this x-ray, but wanted a second opinion and was subsequently referred for definitive care. You look at this x-ray, and this demonstrates some of the difficulties in telling, well, is this fracture united or not? Certainly looks like a pretty clear fracture line there, though there's some haziness, and it may just be that this particular radiograph doesn't catch that non-union, so to speak, at the right angle so you can see it clearly. And if you have non-union in one particular plane and your x-rays are taken in that plane, it can look much like this. And so in these situations, further advanced imaging is often appropriate. And if you're looking at bone, a CT scan is probably preferred. And this patient had a CT scan. And I think if you look at especially the sagittal film on the far right-hand side, you would agree that this fracture is not healed. There is some callus formation. It is attempting to heal, but hasn't quite got there yet, 3 or 4 months after the original fracture. So I think that this probably represents two options here. One is to fix it, which I think might be the conventional option. And the other is if you've got a stable ankle fracture, the mortise is not moved and looks good. There's obviously no infection here. And if it healed like this, I think everyone would be happy, no bad deformity. This represents an opportunity for a LIPUS to make things better. And that was what the discussion with the patient entailed, and they elected to proceed with a LIPUS intervention for this particular patient. And 3 months after the application of the LIPUS, and this is something which is, depending on the device, is designed to be as minimally inconvenient for the patient as possible. Usually in the clinic, I just mark with an X with an indelible marker, and there's lots of those kicking around, where the non-union site is and where I think the device should be applied. 20 minutes a day, and that can be done at the patient's convenience. And this fracture fairly rapidly healed. So you could argue again whether this was just the natural history of this particular fracture to heal, and that might have happened anyways. But I think when you look at the difference between the 3 or 4 month mark, which was the first X-ray, and now 3 months later at 6 or 7 months, there's a pretty significant improvement in this fracture. And I think probably more than you would have expected to see without any intervention. So this is a situation where in a stable fracture, the stable ankle, no infection, no significant deformity, that the biological stimulus of the LIPUS probably, in my opinion, saved the day and prevented another operation. This is the CT scan done to confirm union here, and you can see that there's a significant improvement over what we saw before. Confirming union has occurred here. This is another case. This is a case of mine. Patient from Northern Ontario who fell. This was actually the second go at having her humerus fixed. And you can see that we have obvious mechanical failure here with unacceptable deformity. And I think this demonstrates when LIPUS is not going to be successful in of itself. It may be useful post-operatively, but certainly in of itself, this is not going to save the day. We don't have any mechanical stability here. We've got plates and screws pulling off. We've got windshield washing at the fracture site. And you can see an intraoperative picture which confirms that. This particular patient was a classic tea and toaster, which is, I think, a phrase that was popularized in Britain for usually elderly females who have nothing but tea and toast all day as their main diet. And they often end up in this very poor nutritional situation with low vitamin D, low calcium, low albumin, decreased muscle mass, and all the host of nutritional deficiencies that you see here from that kind of diet. In this patient, in addition to preoperatively having her see a nutritionist and changing things a bit, and there's a actually surprising number of things a nutritionist can do. We refixed this non-union. We added a cortical strut immediately to help augment our mechanical fixation from the plate. And then we added a BMP compound directly at the non-union site. And this produced a fairly gratifying non-union. So this required a preoperative optimization of the patient by a nutritionist. It required a better mechanical fixation of the non-union, and it required a biological stimulus at the fracture site. And with all of those things optimized in this patient, she obtained gratifyingly a union in a short period of time and became an independent person again, where she was not when her arm didn't work well. And this is her down the road, quite happy. Here's another case, an 82-year-old female with 2 failed prior operative interventions. Her ESR and CRP are borderline. Certainly, if someone fails an operation twice with reasonable fixation, and using a DCS for a proximal femoral fracture is probably not something that we would do anymore these days. It was quite a while ago. But again, I think LIPUS alone is unlikely to be successful here. We have gross instability at the fracture site. There may be some underlying infection. We need to do a good mechanical operation here in addition to improving the patient's biology. She had, again, a vitamin D issue, which is common in northern climates with decreased sunshine, especially in the winter. She had a vitamin D supplementation. She had a nutritional and medical consultation so that her medical conditions were optimized. We did improve the fixation. We plan to take this out and change to an IMNL, which in general is a better fixation device. And we also were prepared if we found something unexpected at the time of the surgery, a positive culture. We were prepared to deal with that. And essentially, in a lot of these cases, when I'm doing something like this, I anticipate that on day 4, day 5 post-operatively, one of my cultures or 2 or 3 of my cultures are going to come back as positive, and often staph epidermidis or some low virulence organism is to blame if there's no obvious infection at the fracture site or non-union site at the time of surgery. And if that's the case, what do I want to do during the surgery to make sure that I've done everything I can to deal with that. And so typically all of the hardware will come out, all the broken screws come out, all of the fracture site is thoroughly debrided and cleaned, anything that are devitalized is removed. And then we give a thorough wash with 3 or 6 liters of normal saline, usually under gravity feed. And then we want to leave some powdered antibiotics in a high risk case like this on the way out. So if I do have a positive culture come back post-operatively, at least I can say, yeah, I anticipated that, and I've done everything I can to help kill that infection in a one-stage exchange, so to speak. And doing a staged reconstruction of this might be quite difficult. Some people would go so far as to antibiotic coat the nail they were going to use, and I wouldn't argue with that. That might be prudent as well, depending on what you find intraoperatively. This patient had changed to a nail, and you can see we have pretty gratifying healing with that multifaceted approach to this particular problem. And again, this needs more than simple biologics. It needs a number of things to be successful in this particular setting. No talk on non-union would be complete without a brief discussion about smoking. And I think every fracture surgeon knows that his or her rate of complication, both soft tissue and bone, is dramatically higher in smokers, and it seems to be dose related in that the more a patient smokes, the worse it is. I think now there's abundant evidence to support that intrinsic bias that we have just from dealing with these patients every day. And there is some pretty good information on that. So smoking kills bone cells, and that's a critical thing that you need to get across to your patient. Back a number of years ago, Dave Stephen and I, who's a colleague of mine from Toronto, we looked up our Lizaroff experience. And, you know, Lizaroff is often a last-ditch procedure to try and save or salvage a limb that's failed multiple conventional surgeries. And we did a fair number of these. We looked at 84 patients who we performed a Lizaroff fixation on. We found that we had poor results, and poor results are a number of different things, including chronic infection, chronic non-union, lack of healing, lack of regenerative bone formation, et cetera. We found that we had a 38% rate of poor result in smokers versus only 8% in non-smokers. And this is a pretty decent series 80 limbs treated with Lizaroff. We also found that we ended up amputating 5 of these limbs, and this is, as I mentioned, often a last-ditch effort. And these were all in smokers. So pretty clearly, at least in a Lizaroff reconstruction and circular frame reconstruction, smoking is a negative prognostic factor for outcome and even amputation in this kind of a desperate situation these patients are often in. Well, does stopping smoking make a difference? And I often joke with patients, I say, look, you have a non-union of your bone, you still smoke, I need you to stop smoking when we fix this. Just give us a 3-month window of smoking cessation. And once we get your non-union to heal, you can smoke twice as much to make up for it. That's your business. And they often find that quite funny. And it is a little bit of a joke, but I am actually serious in that they need to stop smoking. It does make a huge difference. So this is actually a randomized controlled trial in the Journal of Bone and Joint Surgery looking at the effect of smoking cessation on the results of acute fracture surgery. And this was a good quality RCT. And they found that they could decrease the complication rate from 38% to 20%. Pretty well cut it in half. Still fairly high, agreeably, but cut it in half by an acute smoking cessation intervention program. And this is directed at a specific event. So I think there's pretty good evidence out there that suggests that if you take someone and try and get them to stop smoking, it can be a hard sell, agreeably. If it's focused on a specific event, so that this person had a heart attack, and you say, look, you had a heart attack because you were smoking and you need to stop or you're going to have another one, then that rate of intervention success is much, much higher. This is kind of similar in saying you had a fracture, you need to stop smoking, get this fracture to heal. And if you do, it'll make a difference. And if you have that event-related intervention, my understanding from literature is you're much more likely to be successful in a smoking cessation program. And there's multiple ones of these around right now. They're pretty good. And you should look into what the resources are available in your area to try and do this. And this is just one paper. I think there's some others that also would suggest this is the truth and can make a big difference. It's pretty clear, I think, that non-smokers do better than ex-smokers who do better than current smokers. So if you're ever a smoker, it's not the greatest, but even just quitting, and it, you know, the old phrase, it's never too late to make a change, it was very effective in this particular setting. Well, what does the literature say about non-union and LIPUS? And I think this is an excellent article. It appeared in Injury just a few years ago. If you look at some of the authors, these are really giants in orthopedic trauma. Ross Layton, ex-president of the OTA, Tracy Watson, ex-president of the OTA, Peter Giannoutis, maybe the most prominent fracture surgeon in Great Britain. They looked at 13 studies that had 141 patients treated with LIPUS. And if you look at those studies, and I did review some of them, it's pretty clear that the same indications that I spoke about in this webinar were used by the authors of those studies. So they were looking at patients who had fairly stable non-unions. They were well aligned. They didn't have active infection. They didn't have unacceptable deformity, etc. So when they looked at those patients, they found they had an 82% overall success rate. And interestingly, found no difference between upper extremity and lower extremity non-unions. One thing that's evident to anyone who does a lot of non-union work is that I would say in general, it's easier to get an upper extremity non-union to heal than a lower extremity non-union. This isn't always the case, but unfortunately the lower extremity is complicated by the fact that statistically, the vast majority of non-unions we face in the lower extremity tend to be tibial non-unions. And there are for sure some around the ankle, as we saw, and some on the foot, and the occasional one in the femur. But most of the non-unions we face in the lower extremity really are tibial non-unions. In the last couple of papers I looked at, it was about 80% or so. And these are very difficult to get to heal. The tibia is a subcutaneous bone with a poor blood supply. It's often complicated by infection or poor soft tissue coverage, et cetera. And so they have a higher failure rate. Interestingly, Ross and colleagues found there was really no difference between upper extremity and lower extremity non-unions, which would really suggest that the treatment of the tibial non-unions is very effective done with LIPUS. And what they did find that was a bit interesting was that hypertrophic non-unions did better than atrophic non-unions in terms of healing. And I think this probably replicates or reflects the surgical literature in that patients who have hypertrophic non-unions typically are not as difficult to get to heal as atrophic non-unions are, and that this is something that is reflected in their paper. And so in general, hypertrophic non-unions, regardless of the treatment, have a better success rate than atrophic non-unions, be that with surgery or with LIPUS or whatever adjunct you are using or looking at. So this is a pretty favorable study suggesting that both upper extremity and lower extremity non-unions can be effectively treated with LIPUS, and that, as you would expect, hypertrophic tends to have a better success than atrophic non-unions. So to conclude, and certainly I presented a lot of information today, and I've tried to be direct and relatively succinct with the references that I've discussed, but there are a number of others that you can look up. If you read the references I've spoken about, then a lot of them have a very good bibliography and references. You can expand your knowledge on this topic. I think that metabolic and nutritional conditions are common in your fracture and non-union population. Certainly they're common in mine, and clearly we did not recognize them as well as we could have or should have previously. Certainly that's the case for me. And I think that we have testing and consultations which are available today that can really optimize your patient so that your intervention can succeed where other interventions have failed. And I think that is really very important going forward, to have someone, a metabolic bone expert or someone you like and trust and work well with in optimizing your patients before you intervene on them in general. You need to recognize these patients and intervene to help them. Bariatric surgery, smoking patients. I didn't talk much about the female athlete triad for the sake of time, but I've seen a number of stress fracture type injuries, especially in active young females who are extremely athletic and who have a very low BMI. They have stress reactions in their femoral neck and the tibiae, and these can be extremely difficult to treat. And that's another patient population that I didn't discuss today for the sake of brevity, where consultation with a medical doctor or metabolic bone specialist, I think, is probably mandatory before repeating any surgical intervention on them. And of course, the elderly with poor nutrition, low albumin, terrible dietary habits, et cetera, are all subgroups that are at risk. And if you see these in your clinic, you need to make sure that you optimize their correctable factors before you operate on them. And that in general, like in anywhere else, carefully planned surgery in a patient with optimized metabolism and biology equals success. And in this kind of situation, I think LIPUS can definitely help you in the specific patients we spoke about, where everything is optimized in a stable, straight non-union that's not infected, then you can often get away without surgical intervention if you do this by optimizing metabolism biology and use a LIPUS. So that's the conclusion of my talk. I'd like to thank you very much for your attention, and we'll now move on to the question and answer session. Well, hello, and I hope that everyone really enjoyed that session. And so now it's time to move on to the question and answer part of the webinar. So we have a few questions already uploaded from this talk. We would encourage anyone else who has questions about it to enter them in the chat box, and I'll be happy to get to them. So the first question we have is, do you manage the gastric bypass malabsorption patient yourself? And the short answer is no. My role in that setting is to identify the patient and to identify the potential problem with fracture healing. So usually the situation is I refer to a patient, or I have one of my own patients who had a previous gastric bypass, had a fracture, had it fixed, and has developed a non-union. So in that setting, before we embark on anything else in terms of treatment, we want to make a clear diagnosis of what the underlying problems are, especially the metabolic problems. I'm fortunate to work here in Phoenix with a Dr. Kelly Crone, who is a superb endocrinologist interested in bone metabolism. So I refer those patients to him, and he does a very careful and dedicated workup, which is far in advance of what I could possibly provide. He gives a good practical advice. We optimize the patient, and then we treat the non-union. And that might involve, in many cases, the use of a LIPUS type device to overcome some of the metabolic deficiencies the patient has, or it might involve further surgery. But either way, the goal is to optimize the underlying metabolic status of the patient so that we don't have to worry about that issue, and we have a much higher success rate when we do so. So I don't generally manage those by myself. Some practical day-to-day things maybe, but in general, the strategic game plan is dictated by someone who knows more about it and is much better at it than I am. The second question is, in fractures due to tumor or malignancy with non-union, what are the pros and cons of using LIPUS? Well, it's an interesting question. And obviously, anything you do that's going to promote bone growth obviously has a potential neoplastic downside. So if you look at the old studies looking at bone morphogenetic proteins, or BMPs, for example, in some of those older studies, if you gave pharmacological overdoses of that material to mice in a mouse model, you could occasionally get an osteosarcoma in that situation. That was something that urged some caution in the use of those kinds of things. But practically speaking, I don't think it's ever been a case report that I'm aware of directly linking the two. And so I think that LIPUS is probably even safer than that. Yes, it's truly a mechanism that induces osteogenesis and promotes bone formation, but I think chance of it creating or inducing malignancy is in my experience zero, and I'm not sure there's any literature on that whatsoever. So I think it's probably pretty safe. The pro, of course, is that it would help get us something to heal, which is often in a very difficult situation. If you have a fracture associated with a malignancy, we know that that bone quality is often poor. The person's metabolic and general nutritional status is often poor. And there's limited time often for that patient. So we like to get things to heal as quickly as possible in a suboptimal environment. So I have used LIPUS in certain situations, mainly for secondary or metastatic disease. I don't treat many primary bone tumors. There's a bone specialist and malignancy specialist in town who does that. But in metastatic tumors that I do see regularly and do treat regularly, I have used LIPUS on occasion, and I'm not aware of any specific concerns about neoplastic progression or formation in that kind of setting. The next question is, what is your experience with non-union non-union fractures in patients undergoing hormone therapy? Our organization has seen a few people transitioning with non-unions and tarsal fractures and hand fractures, and thoughts. Well, I'll first of all say I'm not sure what the right answer is for that. I do know that when you subject someone to super maximal doses of hormones and various kinds of hormone therapies, that there does affect bone turnover, bone formation, etc. And so it's reasonable to expect that you may see some delayed or non-unions in that setting when you're instituting a treatment which may have, or which does have, a specific effect on bone metabolism. I think if I did have that setting, then I would try and treat the individual case as reasonably as possible. It might be that a discussion with the primary care physician or endocrinologist overseeing that transition to talk about the hormone therapy and whether it can or should be altered temporarily to help promote bone union. And if not, then I would treat one of those injuries just as if I would any other, that if the situation is optimal and the LIPUS may be a good idea, especially if it's a delayed union and otherwise stable situation. I think that'd be quite reasonable. I have seen, when I'm thinking about this clinically, I've seen one patient like that. I would say that patient also had a major eating disorder, which probably was the most significant factor. And this patient had very poor nutrition. And we think that that was the major issue which led to the non-union of a fifth metatarsal fracture, actually, that otherwise should have healed or could have healed, I think. And we addressed that feature as well. So I think a discussion with the primary care physician looking after that patient, look for other things that might be going on, and treat as you would with any other delayed or non-union, would be quite a reasonable approach there. What about smoking cessation prescriptions during fracture healing? Do you prescribe anything for your patients? Again, I don't particularly do that. My role, again, is identification here. And I spoke about one of the papers that looked at the reduction in fracture healing complications. I think it was from Scandinavia. So it's pretty clear if you have patients who are heavy smokers or even any kind of smokers, and they have a fracture, it's not too late to introduce some kind of corrective therapy and reduce complications. So every little bit counts, and it's never too late to change, is what I tend to tell those patients. And you can get them to stop smoking, you will probably decrease their complication rate. I focus the conversation around a specific event, and there's pretty good evidence in the literature that if you're trying to get someone to stop a bad habit, if it's event related, focused on a particular thing, and in this case a fracture you're trying to get to heal, the success rate is probably quite a bit higher. And I take a very, I don't preach, I take a very cooperative approach, and approach that we're trying to help you get better here, and this is what you can do to help yourself. In my local environment before and here, there's actually, in my old environment, there was an anesthetic group that set up a smoking cessation hotline, and it was very effective in getting people to stop smoking. Because obviously active smokers are a major concern for anesthetists as well. There's big problems with a number of different issues, airway and pneumonia, and excessive secretions, coughing when they get extubated, etc. So they were very interested in the same topic. And there's similar smoking cessation facilities and resources here. I don't have the expertise to organize and manage that kind of aspect of things for patients. And once my intervention with them is finished, then I won't be seeing them again. And probably it's best if the physician who's organizing this is someone who's going to see them long term, such as their primary care physician. And most primary care doctors now are quite skilled at smoking cessation programs, so I often enlist their aid in doing so. And they've been very cooperative, and they think that this is a good way of getting that patient to stop smoking permanently going forward. So yes, I think it's important. My goal, or my primary focus, is identifying that patient and then enlisting the resources of usually a primary care physician and helping them to stop smoking. That's quite critical going forward. And there's good evidence to support you doing that. And I tell patients, I say, hey, you can look up these articles, but if you stop smoking, the chance to get a wound infection or getting an anesthetic problem or getting a non-union or delayed union is probably significantly less. And I think they appreciate that. The last question I have is a little bit about hardware. And I've been asked this a number of times, is, when there's already implanted hardware, how to use LIPUS? And I'll just reinforce that, is that in general, you want to have your beams going around the device and not through it. So if it's a IM nail, obviously it doesn't make much difference because you're going to get the bone quite nicely there. But if it's a plate or something of that nature, then you want to try and focus your direction, so it doesn't have to go through the plate to get your non-union site. So just a little practical point there to end up. So I think that was a very great question and answer session. A lot of good questions there. Some I'm going to think about actually and look research going forward. I'd like to thank everyone for their participation, and now we'll move on with the next session. Thank you.